So I welcome Dr. Atul Patil sir and Dr. Rutuj Kamdar, who is the convener of the session.
Good morning everyone. Welcome on behalf of Bombay Orthopedic Society for this Wiroc Max. Let me introduce our chairpersons, Dr. Vishwanath Kamble and Dr. Snehal Mayekar. Kindly take your seats. We will be starting with our first session by Dr. Shreenidhi Kulkarni.
Good morning, everyone. I'll be talking on improvement in spino-pelvic alignment in patients operated for high-grade lumbar spondylolisthesis with MIS TLIF. Over decades, we have seen lumbar interbody fusion has been used for various lumbar spine pathologies. Posterior approaches are preferred, and PLIF and TLIF are very popular. TLIF achieves decompression and interbody arthrodesis with less tissue injury and significantly decreased amount of thecal sacral traction. However, there have been concerns with the advent of minimal invasive techniques, there is preservation of lumbar musculature due to splitting of the muscle as well as reduced intraoperative bleeding. And the advantages are decreased pain because of smaller incision and lesser dissection, faster recovery, short hospital stay, and thus faster return to activities of daily living. And there's also documented decreased adjacent segment degeneration by preserving the surrounding tissues. But in case of high-grade listhesis, we have two unique problems when we operate using TLIF. First is achieving adequate reduction to restore the spino-pelvic alignment, and there is always a lingering risk of L5 nerve root injury during the process of reduction. So, with this study, we are being assessing the clinical and radiological outcomes of patients who underwent MIS TLIF for high-grade listhesis. The study was conducted in Kokelaban Hospital, Mumbai during the period of 2017-2020. This is a type of retrospective analysis and a 2-year follow-up prospectively. Radiological outcomes measured were pelvic incidence, sacral slope, pelvic tilt, lumbar lordosis, disc height ratio, and a grade of fusion using Bradwell staging. All patients who underwent MIS TLIF from Feb 2017 to Feb 2020 for high-grade spondylolisthesis, according to Mayekar classification, that is grade 3-4. Which were operated by the same surgeon. The technique, as usual, was after docking the tube, interbody preparation after unilateral SOS bilateral facetectomy, then jacking up of the interbody space using sequential dilators, thus restoring the height, followed by placement of the interbody cage and followed by the reduction. All the surgeries were done using Jackson table, and the advantage being due to the virtue of positioning, we would most of the times get at least one grade of reduction just by the positioning if it's a mobile as in if it is not a fixed listhesis. So these are some sample cases. The 23-year-old female presented with back pain for 5 years, bilateral lower limb radiculopathy, claudication distance of 100 meters, and urinary incontinence since 1 year. We operated with 5S1 MIS TLIF, showed Bradwell grade 1 union in 6 months post-op CT scan. 41-year-old female, back pain since 10 years, lower limb radiculopathy with EHL weakness, grade 3 listhesis, no comorbidities. Operated with underwent L5S1 MIS TLIF, showed Bradwell grade 1 at 6 months. Similarly, a third case of 36-year-old female with 13 years of back pain, bilateral lower limb claudication with EHL weakness. 5S1 MIS TLIF. So coming to the results of the study, there were total of 53 patients included in the study. Majority of them were female being 31. Average age was 47.3 and the average case size used was 12.2, that is around 11 overall. And the disc height ratio was 1.7. The spino-pelvic alignments, there was no much significant change in pelvic incidence, but there was significant change in sacral slope and pelvic tilt. And lumbar lordosis also there was not much change. Reduction pre and post, 48 patients had grade 3 and 5 of them had grade 4. And post-surgery grade 1 was achieved in 47 patients and 6 of them into grade 0. The total 53 patients were involved with mean age of 47.3. Majority of them were female. All were operated in the same institute by a single surgeon. Out of the bed mobilization done on the same day and breathable grade fusion was seen in 51 patients at the end of 2 years. Complications, dural leak was noted in 2 patients. Screw breakage in 1 patient, that is one S1 screw on the right. This was a patient who started doing heavy weight exercises and workouts as well as active work at the home at the end of 1 month, but despite asking not to do. So she came with S1, but there was no loss of reduction, so we just followed up. No cage backout was noted, no neurological deficit, there is L5 deficit was noted, no wound gapes, no deep infections, and no transient neuritic pain. None of the surgeries were converted to open TLIF. Discussion, coming to papers, there's no noted paper showing change in pelvic indices done with MIS TLIF, but yeah, there were papers where high-grade listhesis were treated with TLIFs. Biggest paper I found was by Lebel, where 73 patients were operated using TLIF for high-grade listhesis, showed significant change in sacral pelvic tilt and lumbar lordosis. Our study didn't show any change in lumbar lordosis, but sacral slope and pelvic tilt were significantly changed, noted. Conclusion, MIS TLIF is a safe and effective method for treating high-grade spondylolisthesis, showing recurrent replicable diseases, results with improvement in sacral slope pelvic tilt with excellent union rate. Limitations of the study was a single center, single surgeon based study. Short to medium term follow-up was done, hence there is a need for longer term follow-up to note adjacent segment degeneration and overall global alignment of the spine, where C2 plumb line and all the sagittal alignments were not determined. So that's the shortcoming of the study. Thank you, sir.
Paper is open for discussion now. Sir. How did you measure pelvic tilt? Let me start.
Sir, we had the PAC system. All the whole of the data was through PACs. So the standard where the pelvic tilt, where the line parallel to the superior end plate of S1 to the horizontal was measured. That's it. Normal standard measurements.
I just want to ask, how did you, there were many grade 4 listhesis, did you do acute reduction at that particular point of time?
Sir,
found any difficulty in doing that?
Yes, in 5 cases we did bilateral facetectomy, as in we had docked the tube on one side. The conventional facetectomy was done on one side, and we tried jacking up with pukas and paddle shifters. Okay. Where we were not able to enter, what we did was we went over the top and did the internal facetectomy on the opposite side. Okay. So technically this was bilateral facetectomy done through one side. So that way we were able to open it up.
No, especially in L5S1.
Yes.
So you have to place the screws quite wide in sacral area.
Yes.
So there you found any difficulty?
Most of all the screws were put through using navigation, sir. So we were not having any difficulties. Okay. So we didn't, initially we didn't bother about putting screws. We jacked up the space, then we put the screws.
Okay.
The opposite way. Usually what we do is, if we are using any other way of putting screws, we put the guide wires and then we do the interbody work. Okay. Here we did the interbody work first. That was the advantage of using navigation.
Okay. Thank you.
Thank you, sir.
Just collect your certificate. Excuse me. Yes, sir. Center में. Yes, sir. Yes, look here, sir. Thank you, Dr. Shreenidhi. Our next paper is by Dr. Priyambada.
Good morning, respected chairpersons, seniors, and dear colleagues. At the very outset, I would like to thank Mr. Sandeepan Roy and Mr. Pachumuttu Menikam for helping us in designing the 3D finite element models that we have used in this study. Posterior cervical spine stabilization and fixation is a frequently performed procedure for various cervical pathologies, and instrumentation extending caudally to C7 is frequently needed. The current generation instrumentation systems primarily employ a screw rod design. In this finite element analysis, we aim to compare the biomechanical parameters in case of multi-level posterior cervical fixation, with C7 vertebra being instrumented by two techniques, the lateral mass screw versus the transpedicular screw fixation. CT scan of a middle-aged healthy male individual was utilized to construct a 3D finite element model ranging from the skull base to T1 vertebra, utilizing the Mimics software, Geomagic Design, HyperMesh, and ANSYS software. The literature recommended intervertebral disc heights were maintained, and for our finite element models, the convergence test accuracy was 3%. 4 finite element models were created, with model 1 involving C2 pars, C3 to C6 lateral mass screws, and C7 transpedicular screw. Model 2 involved C3 to C6 lateral mass screw and C7 transpedicular screw. Model 3 involved C2 pars and C3 to C7 lateral mass screws, and Model 4 involved C3 to C7 lateral mass screws. The principles of screw trajectory for posterior cervical spine fixation were followed, and for each model, a preload of 50 Newton compressive force was applied at the superior end plate of C2 vertebra to replicate the head weight along with variation of moment, and the inferior end plate of C7 was fully constrained in every protocol. The same boundary and loading conditions were applied to all 4 models. The maximum moment at failure, maximum angulation at failure, maximum stress at failure, the point of failure, and the intervertebral disc stresses were studied. The maximum moment generated in flexion motion at the time of failure was highest for Model 3, that is the one involving C2 pars and C3 to C7 lateral mass screws. Model 1 allowed least angulation in flexion with 22.5 degrees of flexion. Model 3 allowed the maximum angulation in flexion with 27.8 degrees of flexion. Model 1 could withstand the greatest stress, while Model 4 could withstand the least von Mises stress. Model 1 and Model 2 failed at the pedicle screw at C7. Model 3 failed at the rod at C4, C5, and Model 4 failed at the rod cranially at C3, C4. Model 1 and Model 2 showed lesser stresses at C6, C7 and C7, T1 as compared to Model 3 and Model 4. Ours is the first study to include finite element models to study the biomechanics of multi-level posterior cervical spine fixation with C7 instrumented by lateral mass screws and transpedicular screw. Existing literature includes cadaveric and clinical studies comparing the clinico-radiological outcomes by C7 being instrumented by these two techniques. However, these studies have employed primarily monosegmental or bisegmental fixation models. Clinical studies require a lengthy follow-up, and conducting cadaveric studies in our setup is very expensive. We hope to confirm the validity of existing data with this finite element study and use the present study as groundwork for future such studies. The maximum moment generated at failure was lower for constructs terminating with pedicle screw than lateral mass screw, and this is attributed to the fact that pedicle screws have a longer lever arm spanning across all 3 vertebral columns, whereas the lateral mass screw anchors only to the posterior column. So transpedicular screw at C7 provided a stiffer subaxial construct. The maximum angulation of the model was also greater for constructs terminating with lateral mass screw as compared to pedicle screw at C7, and this again is attributed to the tricolumnar purchase of the pedicle screw as opposed to lateral mass screw fixation, which controls the posterior vertebral column only. On loading the models with compressive force and flexion motion, accumulation of von Mises stress over the implants was greater for models terminating with lateral mass screw at C7, and the variability in stress at each intervertebral disc space was also greater for models terminating with lateral mass screw. This indicated a greater possibility of fixation device fracture with constructs terminating with lateral mass screw as compared to pedicle screw at C7 level. Von Mises stress at C6, C7 and C7 T1 levels were lower for constructs terminating with pedicle screw, and this was indicative of the higher stress shielding by the pedicle screw at C7 level. For both models where C2 fixation was done, lower stress was seen at C2, C3, and so adding a C2 par screw increased the constraint of the construct and ensured lesser variability of von Mises stress across each disc space. This in turn reduced the risk of implant-related fracture and complications. The take-home message today is that ending a multi-level posterior cervical construct with transpedicular screw at C7 provides a stiff, more constrained construct system with higher stress endurance to compressive forces. The constraint and durability of the construct can further be enhanced by including a C2 par screw to the fixation system. The current study with these finite element models paves way for future more possible research in this arena. Thank you.
Excellent paper.
Thank you, sir.
The paper is open for discussion.
But still, I would suggest that traditional way of doing all these studies on cadaveric thing would be much better, because these studies are to be replicated in live. So
Yes,
what
sir.
is your
So-
take on that?
I agree with that, sir, but with cadaveric studies, the simulation of the load, and especially with this study, what we were aiming to do was we are planning more finite element study for complex surgeries, like combination of anterior as well as posterior approaches to the cervical spine, multi-level cervical stenosis models. So that becomes a little difficult when we are dealing with cadaveric models, because A, it becomes expensive, the ethics, the setup of the cadaveric study. And so with this study, if C7 pedicle screw is better than lateral mass screw is a known fact. We already know that. So this just gives us a boost that the finite element studies, the models that we are creating, it's taking us in the correct direction. So we can deal with more complex studies with these models, which becomes difficult when we are conducting cadaveric or clinical studies. Clinical because it takes a very long follow-up to come to any conclusion, and cadaveric because of the technical difficulties and the cost issues.
Okay, that is good. But one more point I would like to ask. At C7, you said about a lot of stiffness and because of the fixation. So how about the functional? Is it possible to study that in this particular models? Functional outcome of, like, patients or maybe the future.
So for multi-level cervical fixation models, we need a stiffer construct, because if we allow a lot of flexion or allow a lot of movement, it gives chance for implant-related complications. So when we are dealing with cervical spine and multi-level fixation, we actually want a more stiff construct as compared to one which is allowing more movement.
Okay, thank you.
Thank you, sir.
Yeah.
When you say you use 3D models versus the cadaveric studies,
No.
if we consider cadaveric studies, it would be more to better, because once we use 3D models, we are removing the soft tissue elements altogether.
We have mentioned that as...
So the stability any day would be better.
Of course,
with
yes.
the cadaveric studies.
Yes.
That's
That I agree with that. That is a limitation of a study. One, that it removes the soft tissue part, and the other that it removes the possibility of any micro motion between the bone and the screws. That is a limitation of the study.
I request respected chairpersons to issue a certificate of participation. Thank you, Dr. Priyambada. Next speaker is Dr. Deepika Jain. Yeah, please start.
Good morning, one and all. I'll be presenting a paper on the short-term functional outcome of total hip arthroplasty in COVID-related hip AVN. During 2019, we were hit by a pandemic, the COVID-19 pandemic, which has affected 660 million people across the globe. During this pandemic, steroid was used as a novel drug to fight against this deadly virus and the cytokine storm. But as we know, steroid always acts like a double-edged sword and has affected patients in various ways. One of the side effects of the steroid is that it causes osteonecrosis of the femur head by increasing adipogenesis, increasing the osteoclast activity, venous occlusion. But is steroid the only culprit? So, studies have shown that virus downregulates the ACE2 receptors, causes cytokine storm, and causes the patient's body to go into a hypercoagulable state. It is also observed in the study where they have observed that there is osteonecrosis of the jaw. Similar mechanism, and with the help with the steroid, the patients have undergone microthrombosis of the femur head, which causes ischemia and avascular necrosis. This avascular necrosis can be graded according to the Fickett-Arlet grade as in 4 grades, the 4th being advanced arthritis. The amount of osteonecrosis can be calculated by the Kerboil's angle on AP and lateral radiograph, which gives a combined necrotic angle and the amount of the collapse the patient's femur head can undergo, which can be graded as grade 1 to grade 4 being the most severe, which is more than 300 degree. My aims and objectives of the study is to compare the functional outcome with high-risk score in pre-operative and post-operative total hip arthroplasty in the COVID patients, to compare scores post-operatively in the COVID and non-COVID group, to study changes in the osteonecrotic pattern in the femur head. Since January 2021, there were 40 patients who underwent uncemented total hip arthroplasty at a tertiary care center, which were divided into 2 groups, the COVID group and the non-COVID group. These were the patients who we excluded from the study. My study had 42 patients, 13 in the COVID group, 29 in the non-COVID group, and the requisites that we wanted from the patient were the X-ray, MRI, pre-operative and post-operative high-risk hip score in the COVID-related hip avian. My first case is a 48-year-old female who was COVID positive in the August 2020, who had an ICU admission, received steroids, which was less than 1000 milligram. Patient had pain after 6 months, which was in the left hip more than the right hip. And this patient had a modified Kerbal score. Score in the right side is 226 and on the left side it is 334, which is grade 3 and grade 4. My case 2 is a 30-year-old male who was COVID positive in April 2021. This patient also received steroid for over 15 days, 40 milligram BD and then 40 milligram OD. Hip pain left was more than right. This started in November and patient received alendronate in this pre-alendronate picture of the hip X-ray. And after 6 months, as we can all see, there is global worsening of the patient's femur head. This patient's MRI also shows a combined necrotic angle, right side 225 and left side 254, which falls into grade 3. All these patients were operated with total hip arthroplasty, and these are the functional outcome post-operatively in these patients. As we can see, patient has achieved normal gait after total hip arthroplasty bilaterally. Results of my study, our mean age of the patient was 40 plus minus 8, with 2 patients being 65-year-old and 1 being an outlier, an 84-year-old male with no comorbidities, no steroid admission, with COVID positive 6 months back, which is a rare finding because usually we do not see hip avian in plus 60 age group. My 11 patients were male, 2 were female. All cases in the COVID group presented with bilateral pathology. Steroid intake was seen in 9 patients out of 11, and all of them had less than 1000 milligram MPS equivalent. Maximum of the patients had ICU admissions. The duration of onset of symptoms was 6 months after the patient tested positive for COVID. As compared to alcohol abuse, what we see is patient presents after 8 to 20 years, mean being 9.5 years, and the age group is more than 50. The high-risk hip score improved significantly after the THR in the COVID group, but there were no significant difference that we found in the post-operative COVID and non-COVID group. This is a video of a bilateral hip total hip arthroplasty patient. As we can see, the patient is having normal gait. This is a paper that shows that post-steroid intake in a patient, the patient usually has superior retinacular arteries, which are more stenotic, and the draining veins in the superior superior compartment, which decreases over time, and hence patient has sectoral involvement after weight bearing. In this meta-analysis, which took place at after the SARS 2003, where 1137 patients were evaluated, and they found out that less than 5 grams of methylprednisolone and less than 30 days of administration of methylprednisolone has a very low risk of osteonecrosis, as compared to our patients who fall in the less low risk group. These are the X-rays of the 6 out of 11 patients where we found rapid destruction and the combined necrotic angle in the grade 3 and grade 4. So the take-home message is arthroplasty is a key to severe osteonecrosis, which increases the Harris-Hipp score of the patient. Virus and steroid act synergistically, as our patients had a very decreased intake of steroid, so it cannot be the only pathology causing hip AVN. There is an increased combined necrotic angle which was found in maxima of the patient with globular and rapid destruction of the femur head. Things that need to be evaluated is elderly hip AVN, which we usually don't see. Virus-induced AVN, as my sample size was less, we need more sample size, and global and rapid destruction of the head. Thank you.
Paper is open for discussion now.
Okay, doctor, the question is, while evaluating the patients,
Yeah.
you said that there were 2 patients who were not given steroids.
No history of
Other
steroid.
than steroid and COVID, were any other...
I have excluded patients. In the study, I have mentioned it, that I have excluded patients who had history of steroid intake due to other reasons and were COVID positive. So patients who had sickle cell anemia or thalassemia, hemoglobinuropathies or alcohol intake or steroid with COVID positive as well, those patients were excluded. So single pathology was considered in both groups.
And one more thing you mentioned about alendronate and pre-alendronate.
Yeah.
So what was the difference between that?
So in the
Did you find that collapse was much lesser or slower in that pre-alendronate or alendronate
the
group?
patient was given alendronate when he was in stage 2 of at the fictalate rate, where usually alendronate do act in the pre-collapse state. But this patient we expected that alendronate would work, but within 6 months there was gross collapse seen in this patient, so I mentioned it.
That means you mean to say that with the COVID and the steroid, they are acting synergistically, which is proving your point that collapse is much faster and causing hip score
but
also.
I cannot definitely say that because we need, that was
study,
one patient, so
study,
we need more study
you
sample
need more
was small.
study sample,
Yes,
okay.
yes,
Good,
sir.
good, thank you.
Thank you, sir.
Thank you, Dr. Deepika. Please collect your certificate. Our next speaker is Dr. Tushar Agrawal. You can please start.
Good morning all. So we've coined a new terminology called the disappearing pulse in the supracondylar fractures. Let's see whether it holds its fort. So what we are talking about is a pulse which, I'll go to the next slide. So we know that there is a pink pulseless hand, there is a pale pulseless hand, and we've coined something called as the disappearing pulse hand. So let me explain what it is. So we are referring it to a clinical condition where in the severely displaced supracondylar fractures of the humerus, with a sharp medial spike in the proximal fragment and a large swelling, the patient presents to you with an intact radial pulse, which is bounding. Once the patient is induced, the pulse is still intact, but the pulse immediately disappears when the close reduction is initiated and completed in hyperflexion. The pulse may or may not come back, and but the moment you start the close reduction again, the pulse disappears. So the literature calls this also as a pink pulseless hand, but we call it the disappearing pulse hand. Even the AAOS guidelines is inconclusive, as you can see from the lower slide, that if there is absent wrist pulses with a perfused hand after reduction of the displaced pediatric supracondylar fractures, it's inconclusive whether you need to close or open treat these patients. For the purpose of perfusion, we've used the strength of this paper to use pulse oximetry. So we studied a very small cohort of 5 patients. This is a very rare situation of grade 3B and 4 fracture supracondylar, all of whom lost their pulses on attempting the close reduction. The pulse was documented and present before the close reduction. We treated all of these patients with a small open incision taken over the antecubital fossa, and we removed the interposed soft tissue, followed by close reduction, and regular lateral pinning by 3K wires were done. The purpose, what we were doing this for, to actually document the fact that this open reduction is essential in these kind of fractures. So this is the way we have gone about the whole procedure. It's very simple. We have taken a transverse incision of about 1 to 1.5 centimeter on the antecubital crease. And wires were removed after 4 weeks. And we found that the moment we would do the open reduction, the end point of reduction was very firm and the pulse was bounding. And there was no problem with the pulse oximetry. Initially, outside of our paper, we had done for about 11 cases open reduction, but we narrowed down by putting these inclusion criteria. So we included only confirmed supracondylar fractures, only those with a sharp anteromedial spike were included, and we were using only the ones which had lost the SpO2 waveform and all those who were open from the medial side. So we excluded all doubtful diagnosis, means distal humeral fractures, all other forms of displacement. Whenever we used a collateral approach, we have excluded that. The ones in whom we didn't have SpO2 loss, we have excluded that. This is just to show an example of what we excluded. So the bruise is on the lateral aspect. So these kind of displaced fractures we have excluded. So very simple conclusion, we found that after removal of the soft tissue, the pulse returns immediately. In spite of hyperflexion, the waveform improves completely. The reduction has a firm endpoint. The anterior fracture gap goes away. And post-operative, immediately or later on, no patient has evidence of any compartment syndrome. One patient in whom we had a fair result was a very significantly displaced fracture in whom we had to use a JES fixator. She is still under follow-up. She is the last patient whom we have had. Now, all the available literature actually suggests that you reduce these fractures, fix and wait. And only when they develop symptoms, you may then do an intervention, right? Now, we think that no, this is a separate entity, right? So the patient, when he presented to you, had the pulse, had no symptoms. You caused the disappearance of the pulse. So you don't know when the patient comes out of anesthesia, whether he is going to have any symptoms or not, whether you have entrapped the median nerve, entrapped the brachial artery. So what we are trying to say is that no, go in, open, that small medial incision is very simple to do. Eventually, once you get a hang of it, remove the soft tissue interposition, which will take away the brachial artery and the median nerve by itself. You don't have to make a specific attempt to look for it. Just digital dissection, just a finger dissection or blunt hemostat dissection is enough to get the soft tissue out. So what is our conclusion? That if you want to solve all your problems with no worry, open the patients in whom you have caused the disappearance of the pulse. So this is our first case where our incision was a little wider, little more open. Then as we got the hang of it, then the incisions have become smaller. This is the patient in whom we use the JES fixator. This is a full case example, sharp anteromedial spike, the bruise increasing next day morning. The waveform changes, the pulse oximetry may not come down very low, but the waveform changes as compared to the normal side. There is an anterior fracture gap. So you decide to open. You get a very good outcome, and as you can see, even with the L-shaped incision, the scar is fairly acceptable. So the literature is very wide and varied. Some say don't ever open. Some say that only when you have signs of median nerve, then you open. Most say reduce, fix, then do Doppler or do some other form of investigation and then reserve to open. But the latest study by the Sabharwal group says that maybe open is now added to all patients, as the evidence is very grey for not opening. And we did a cadaveric dissection, and you can see this is just the small medial open. So when you open the full wound, you find that it's technically very easy, and the small medial open scar comes actually over the common flexor pronator origin, so it's very easy, it's not very difficult eventually. So thanks a lot.
The paper is open for discussion. Any questions? Sir, what exactly were the findings when you open it? Most common findings.
So in the patient in whom I actually opened big and wide, it was tenting over the sharp medial spike. But afterwards, gradually, I find this very harassing because you're not really prepared for this kind of surgery. You're all alone, you're doing a supracondylar. So we started just taking that medial antecubital and just digital dissection. So you push the fragment back. Sandeep Patwardhan says you can even use the suction cannula to just push the fragment back. And it's more of a feel. You feel the fragment has gone and the soft tissue has come up. So you don't have to see anything. What I'm merely trying to say is, don't treat this as a pink pulseless hand. Don't wait on it because you have caused the pink pulseless hand. The pulse was present when the patient came. It's slightly different from the actual pink pulseless hand where the patient is awake when you have seen that there are no median nerve signs and you have decided not to open and reduce. I must add that I used to open all, then I have now got 2 patients in whom I have gone against myself and I have closed, reduced and waited. And I have found that maybe I was doing an overkill, so I added the other factor of a soft endpoint of reduction. So it's not just disappearing pulse with SpO2, but you should have a very soft endpoint of reduction. That means for sure you have interposed something. Otherwise, when you reduce, you get a very firm thud of reduction and there is no anterior fracture gap.
Very good work.
Yeah, I agree. You doing proactively that open is very nice thing because many times we have not realized it and you have proved it. Opening, small opening in such supracondylar fracture is really boon. But one more small technical point. Do you apply tourniquet and do it or?
So I have applied tourniquet in all patients, but I have not elevated. The reason I have applied is that I don't have anybody else there. So if there is a crisis, I can at least elevate and do the.
Okay.
So I always keep it applied.
But did you really, when you do digital, that time you found that brachial artery was pulsating?
So yeah, you can feel the pulsation and you don't end it till you can feel the pulsation of the brachial artery in the front of the elbow.
Okay. So you think that there was no spasm of artery or anything that time when you opened?
At least in these 5 cases, but the cohort is very small for me to really comment. But in these cohort, I feel, see, the idea is I have caused the entrapment. No, the spasm is in the pink pulseless hand. The pulse was anyway bounding till I close reduced. The moment I close reduced, I don't think I can cause a spasm. I have entrapped it.
Yeah, that's good. Even the open reduction and in that crease line, scar also doesn't bother in small children. So
it is little stressful as an orthopedic surgeon. I must say you are
definitely
not used
to. Definitely it is. Yeah, and plus we have to convince the patients and relatives.
3-year-old child to make that incision, but that's what I proved on the cadaveric dissection that you're really far away from everything vital. So the moment you keep the cadaveric dissection image in your mind, now you feel more confident. Khali thoda fascia kaatna hai, I am on the common flexor pronator origin and then just with my finger I can push the fragment back.
Okay.
Excellent work. Thank you so much. Please collect your certificate. Our next speaker is Dr. Mukhi sir. So, is he there? Okay.
The panelist in the next discussion in 1C.
Okay. So the next speaker, Dr. Ronak, is ready. You can start presenting.
Good morning, everyone. Does the patellofemoral alignment affect functional outcome after total knee arthroplasty? The traditional presumption that correct alignment is imperative to ensure long-term survival has been a matter of debate. However, most of the studies have measured 1 or 2 parameters of malalignment. Assessment of multiple parameters is crucial for correct evaluation of the prosthesis. Prosthesis malalignment can lead to problems of the patellofemoral joint like the anterior knee pain, the patellar subluxation, which are a common cause of dissatisfaction after the surgery. In a study by Christoph in 2002, no, he did not find any correlation between the patellofemoral parameters and the anterior knee pain. In Christian Bach et al. In 2009, conducted a retrospective study and found no correlation between the prosthesis malalignment and functional outcome. However, the insult-salvati ratio was not assessed. In 2018, the study by Rakikart found strong association between the suboptimal poor patellofemoral alignment and poor clinical outcome following total knee replacement. The aims and objectives of my study were to evaluate the radiographic patellofemoral parameters before and after TKR, to assess functional outcome of patients using patient-reported outcome measures like Oxford Knee Score and Knee Society Score post-operatively, and to correlate the prosthesis alignment and patellofemoral parameters with the functional outcome of the knee. It was a retrospective study in which the patients undergoing primary total knee replacement were included, and with a minimum follow-up of 6 months. Any patient with a history of previous knee surgery with revision knee replacements or any complication developing after total knee replacements like infection, fracture or neuromuscular damage were excluded from the study. All TKRs were performed by a single senior orthopedic surgeon with a standard midline incision and a medial parapatellar approach. Standard postoperative mobilization and rehab protocols were followed, and all the readings were assessed by 2 independent observers with a follow-up of 6 months to 2 years postoperatively. My methodology had a radiological assessment of preoperative patellar tilt, which was the angle between the transverse axis of the patella and the anterior intercondylar line, and the postoperative tilt was measured based on the angle between the anterior limits of the femoral condyle and line drawn through the prosthesis bone interface. The preoperative patellar displacement was calculated by the lateral displacement of the median ridge of the patella from the intercondylar sulcus, and the postoperative patellar displacement was measured as the distance between the center of the patella and a line drawn through the center area of femoral condyles. The insult-salvati ratio, being the ratio of length of patellar tendon to the maximum length of patella, was assessed. All the radiographic parameters were measured on the preoperative and postoperative radiographs, weight-bearing anteroposterior and supine lateral radiographs with axial skyline views. The coronal femoral angles and the coronal tibial angles and the flexion femoral angle and the sagittal tibial angles were assessed postoperatively on the radiographs. The functional outcome of the patients was assessed based on the patient-reported outcome measures, the Oxford Knee Score and the Knee Society Score. The Oxford Knee Score having the best outcome with a score of 48. It mainly focused on the satisfactory elements of the patients instead of the surgeon, and the Knee Society Score having a best possible outcome of score 100. In our study, on 77 knees, the mean preoperative insult-salvati ratio was 0.975, with preoperative patellar displacement 4.88 millimeters and the patellar tilt being 7.4 degrees, and the patellar thickness as 23.36 millimeters. And the similar postoperative values of the insult-salvati ratio was 0.995, with the patellar tilt and displacement at 5.35 degrees and 3.4 millimeters respectively. In the study, it revealed that amongst all the radiographic patellofemoral parameters, when compared with the Oxford Knee Score and the Knee Society Score, found correlation only with the preoperative and postoperative insult-salvati ratio to be statistically significant. The difference in the mean Oxford Knee Score and Knee Society Score in optimal versus suboptimal group comparing patellar tilt and displacement turned out to be not statistically significant. In conclusion, the decreased insult-salvati ratio postoperatively is associated with the inferior functional outcome scores, and the radiographic patellofemoral parameters like the patellar tilt, displacement, thickness have no effect on the functional outcome on short-term follow-up duration of 2 years. Thank you.
Very good study. The paper is open for discussion. Any questions?
Thank you.
Yeah. Thank you, Dr. Ronak. Please collect your certificate. Yes, sir.
Just wanted to give a comment on that. That is the study was.
Yes, please, sir.
I'm a co-author there. That you have talked so much about coronal alignment and all, and probably we have solved the alignment issue. Now there is a restricted kinematic alignment, that kinematic alignment, adjusted mechanical alignment. But patellofemoral issues has not been addressed so much in the literature. So it doesn't matter except only that joint line insult-salvati ratio to be restored within 5 millimeter. Functionally it will be, patient will be happy. So functional doesn't make a difference, whatever tilt or whatever, those are only for research purposes.
Thank you, sir.
Thank
Our next
you.
speaker is Dr. Mukhi, sir.
Yeah.
Sir, please start.
Thank you, sir. And I thank the organizers of the Bombay Orthopedic Society, Wiroc, and all my delegates. This novel technique, which I am going to discuss, is encouraged to me by the president of the AAOS. Please wait. Don't go. You will not get to see this in your life. And this gives me the passion to present it. What is the incidence? 37,000 per lakh. High energy trauma, low energy in elderly people. Two components, mainly the intercondylar and the supracondylar. We all know C3 classification, simple, wedge, multifragmentary, and bone loss. What are the surgical goals? We want an anatomic reduction. Why? To prevent TKR, to prevent Mohanty from becoming the president. We want the articular surface to be very good. And not only that, the metaphysis also. Restoring the length, because if a lady like Podium comes, you think I'll give her a short leg? No. I must get the alignment, rotation, stability on day one. And who coined the word day one? I'll tell you. These are various implants which have come and go. And you heard Professor Thakur yesterday. What an implant he showed. Marvelous implant. I miss him today. He should have showed that implant today also. What matters most is here. This is my implant, my brain. And you can avoid all these complications if you follow the right technique. And what is the right technique? Feel the adductor tubercle, and you know the descending genicular artery medially, which supplies the blood on the medial side. So lateral side, you are destroying it because it is easy, and you can get the fixation. This is the fracture. Do you know that it is intra-articular also? Yes. And this is the void. You see the void. How much is the void? Right from here till here. This column is not reconstructed, you will fail. You will say it is an implant failure. I say it is a surgical failure. It is a mind failure here. The implant never fails. It is the surgeon who fails. If you accept it, then you will learn. Yes, various augmentation techniques are there. You may fill it with synthetic bone, you may fill it with bone cement, you may add an additional rod. All these will work when there is a gap of up to 2 centimeters. There is a paper by the Italian registry that this void, more than 2 centimeters, medial plate has to be longer, nail has to be stronger, and whatnot, and the graft has to be augmented. And this is what we did. Harms. It is not harms. It is my savior. It is not harming me. It is saving me. That is the word I coined. And what will you do in this? The surgeon was kind enough to nail the tibia. And he was so kind enough to refer to me. He said, Mukhi, I can't do this fracture because it has got a gap of more than 10 centimeters. This was my first case. God bless. And this came the Harms technique. And what is the Harms technique? It's the Harms cage, which has been built here to get the medial column without disturbing the medial biology. Can you see that? What is going to be the result? Day one failure or day one success? Anybody? Success. Who coined this word? Again you succeeded. That's right. And your guess was right. And that's it. Not because I'm presenting it, because this has highlighted me and saved me from this disaster. See this patient, unmarried, now he's married, and fortunately, he has got 14 children. No, sorry. wives, girlfriends. Girlfriends.
28 children.
A good guess. Which femur is fractured? Monty, sir? Please. No. Can anybody guess? Left side? Okay, let's see. What a disaster it is. What a disaster it is. You see the combination, you get afraid. You're a nightmare. And this is the girl after 4 months. Where is this technique described? Nowhere. Right? So it is originally innovative. Right? The scar is there, but the biology is not disturbed. I'll go a little faster. And this, oh my God, 45-year-old male, and this osteoblastoma or chondrosarcoma operated in Tata Hospital. The case was referred to me, and what I did, oh God, again a Harms case, and you see the result. And I wrote to Professor Jagan Harms, and what he said, my dear Mukhi, please present it immediately. This is his email. And what are the advantages? Less periosteal stripping, no neurovascular damage, and that's why the Harms case, right? This is good evidence of bony stock, and this is a novel method which Professor Christian Kratik, president of the AOS, congratulated me in the TraumaCon. He said, please go ahead and publish it, and I published it. I thank you for your attention.
What a paper and really innovative technique. Okay. Any questions? I hope there are no questions. Everything is crystal clear.
You have to be foolish to become Steve Jobs. Stay foolish and stay inquisitive. How do you remove this cage? That is one.
You put bone grafts inside the...
Yes, of course, I told them. You have to augment with bone grafts.
Autograft or allograft?
Huh?
Autograft. So you crush them and put it in?
Yeah, put it with antibiotics also. What's wrong?
With gentamicin?
Huh?
Gentamicin antibiotic.
I put vancomycin.
But how that cage remains stable there? It doesn't move?
What cage? Yeah, that technique, you pass it onto the medial cortex.
A small video to
yes,
the technique.
I should have. And I'm doing it. But before I show you the video...
Why not fibula instead of cage?
Fibula, I showed you, it failed. Done by my colleague in one of the best institutes. The fibula which you put over there is not having the strength enough to withstand mobilization. It fails. This cage is a titanium cage and got the idea from the spine. I'm a spine surgeon. And he did now an expandable cage.
In between the two screws, you fix that cage.
You can. If you are not getting a good hold, approximately you get a good hold because the cortex is good enough. Distally it is a cashless bone. You may not get a good hold, so you can pass.
So you immobilize it for how many?
No immobilization, my dear.
Immediate CPM.
See the movement, that girl, 24 years, she says, I want to get married, and you can't make out which hip is damaged.
What was your answer, sir, when she said, I want to get married?
Come to me.
So post-trauma, like in how many, like if you have a choice to choose, like when to operate this patient, when, like do you let it the combination to consolidate a little bit, or whenever the patient presents?
That wound depends. Depends. That can depend. Wound has healed.
No,
The first case I did after 14 days. The second case I did it immediately. There was no bone outside. Wound was good. And
what will you do in compound fracture?
They are all compound. C3 compound. You see the bone projecting out.
Debridement, external fixator.
Yes, that all is done. Now you want fixation, then do that.
So this is for definitive surgery.
You will do in tibia also?
Tibia,
like,
I showed you.
No, it's a floating knee, suppose.
I showed you in the tibia, chondrosarcoma.
No, that is only one chondrosarcoma, but I meant to say
Plateau, I did it in the humerus.
same technique.
Yes, I forgot the fibula. And now I am taking grafts not
So
from
can
the
we then call it as a Dr. Mukhi's technique to fix in various fractures, metaphyseal fractures with
Provided
bone loss?
You don't harm Harms.
Yes.
Don't harm Professor Harms. Yes, you can call it my technique.
Congratulations, sir.
Thank you. Thank you, sir. Thank you.
Sir, please collect your certificate. Sir.
Excuse me. I am a student all throughout my life.
Thank you, sir.
Thank you.
And our first session is over now. Thank you, everyone. Thank you, respected chairpersons.
Thank you.